suddenly and forcefully dislocating those. And those really stabilize the opening of the spine of the vertebral frame as we've got space for the spinal cord. So cervical spine and slight flexion results in near linear column. Axial load to linear column begs for disruption to ligamentous integrity or structure. Axial loading. So you go into spear, you drop your head in football, you put that entire, all those spinous or vertebral bodies and the spinous process in a direct line. You don't have any leverage for muscles to help out. And so everything goes into pretty much damaging one or multiple locations. So you can see how this space right in through here is completely collapsed down. Axial load hyperflexion are the predominant vectors of history. Severe neck pain and neurologic deficit, either radiculopathy or evidence of acute traumatic spinal cord insult. So how do you do that eval on this person? How do they present to you? When you go and you watch this person, they drop their head, they spear somebody, they hit another player head on, and they immediately hit the ground. How do you do that eval? How do they present to you? What symptoms are they going to give you?
Maybe dizzy.
Okay, maybe dizzy.
You may not be moving.
Blurred vision.
Perhaps. So vision's getting into more cranial nerves and not so much distal. So if we're looking at a C-spine, we have to look at whatever is here and down.
Muscle function.
Muscle function. Are they in pain? Probably. Not always. Because there is the capacity for people to have shock hit well enough and quick enough that they don't feel much.
Would there be like physical deformities?
Potentially. If it's an axial load, you typically won't have a lot of deformity that's visible externally. Likewise, if they're, well, I guess even more so, if they've got shoulder pads and a helmet on, you can't really see the neck anyways. I'm going to say there's going to be up here a whole lot of freak out, potentially. The pain is going to be significant. Most often the pain is going to be a problem. Well, they won't be getting up most of the time. If they've got radiculopathy, then they're not going to have movement in their hands and legs, or one or the other. So how do you assess that? What's your first move when you come across that person? Like, oh, that sucks. What do you need to do?
Check to see if all their vitals are good.
Okay, I would check ABCs first. Airway, breathing, circulation. Are they alive? Do I need to have that as my primary focus? This kid's yelling, my neck, and you saw them spear, so you've got a really good indication that we have a spinal injury, so what are we going to do from there?
Stabilize.
Stabilize. So, hold C-spine, get your hands wrapped around the neck. You guys been taught how to do that? No? Would you like to learn how to hold C-spine?
Sure.
Really like this.
Sure, I need a volunteer. Come on up.
As I did it one time.
You need two people.
Okay, be dead. Well,
Usually.
sorry, be injured.
Or two, that's just triangular, right?
Huh?
That's
All right, lie
triangular.
back.
I just learned that, like, I learned this in CERT.
Okay, so C-spine.
This.
Really easy concept here. Your hand kind of. You kind of use the heel of your hand, your hypothenar eminence. Remember these terms, right? So you use those and kind of hook into the occiput. So you kind of feel your hand right back into here, and the catch is once you put your hands holding C-spine, you're not allowed to let go until it's a stabilizing move, until EMS is walking in and putting blocks on her head to help strap her down. You don't let go. So once you make this commitment, unless you're alone and they stop breathing or stop having a heartbeat, or unless there's a significant risk to your life to be in that spot, you don't let go. So get comfortable, because you can be there for a while. Average EMS response by region can vary anywhere from 5 minutes to 15 minutes. So typically you kneel down, get your elbows on the ground to where you're good and comfy. And you can kind of use body weight rather than muscle strength to do this. Because if you're there for a while, you're going to get a little tired if you pick the wrong spot. So all we're doing is really kind of just cradling the base of this right along the spine, but use the heel of your hand right down and through here, hypothenar eminence, to catch the occipits. And you're going to pull about, I don't know, 2 to 5 pounds worth of traction. And just sit. Feel it pull. Yeah. And then try to turn your head. So even if they want to, they really can't, which is part of that help as well, because they might be freaking out, and you're just sitting here talking to them. Hi, how you doing? Doing all right? Yeah, a little uncomfortable? I get it. No big deal. We'll get lollipops when we're done, okay?
Okay.
Cool. Good talking to you. So it's really just kind of hooking the heel of your hand up underneath that occiput and cradling up. Because if you get that and then kind of wrap the ear, they're not going to go anywhere. Now, if you're trying to grab a little higher up off the occiput, you're going to be trying to pull on something here, which isn't going to work as well. But if you can catch that occiput, you've got more leverage to kind of hold. You've got a ridge, a nice big fat ridge, to kind of hook your hand and get the traction on. Cool. Yeah.
It'd be a lot harder if they had a helmet on, though, wouldn't it?
It can be. And a lot of times with helmets, because the helmet's there, they're not going anywhere. So you can actually hold the size of the helmet knowing that they can't really move. So that works as well. Now, but you've got to know your sport as well, because if you start getting into other sports, lacrosse, they have shoulder pads, they have helmets, but it's different. Their shoulder pads are almost paper thin. So it's more acceptable to be able to get that helmet off to maintain airway. Football helmets are just, there's so much thickness here, and the pads are as well, that if you pop that helmet, then their head's going to fall back. So there's drilling and training you can do if you have to pull them off, that you can take them off together, but that takes some coordinated effort. More often than not, what you're going to do is pop off the face mask to get access to the airway. But even then, you have to know the equipment you're working with, because some helmets, you lose all structural integrity to the helmet by taking off the face masks. The Rydell Revolutions, they're actually designed to look like motocross helmets, so they come forward here. And if you pop this, then everything through this region becomes almost paper thin. It just flops around. And so recognizing it's almost as good to pull those off with the shoulder pads, because you're going to lose any kind of stability with that helmet at that point anyway. So there's a trick to knowing the equipment you're working with and how you kind of approach these individuals. But regardless, stabilize the head, and then from that point, what are you going to do in your assessment? Or if you have a second person, what's your second person going to do?
Dermatomes? What?
Dermatomes, myotomes, we're going to assess nerve roots on down. So start distal, work your way up. Can you move your feet, dorsiflex, plantar flex? Good. Can you wiggle your toes? Excellent. Can you lift your leg up off the ground a little bit? Okay, just so we know we've got activation there. Can you feel palpate all the way down? And while you're doing this, you're looking for secondary injuries at the same time. Are there other traumas that we have? Are there other lacerations, other conditions that might become life-threatening if we don't deal with them? Bleeding wounds and so forth. And then likewise with the arms. Can you hold my hand? Squeeze my hand. Good. Well, then we know we have grip strength, we have hands, we have strength of the forearms. Can they pull up, push down? So biceps, triceps, do we have those? And can we push out for C5 on deltoids? Now once you get above that, your screen for C1, 2, 3, and 4 is look up, look down, left and right, and then shrug your shoulders. I can't really have them do much of those in these positions because I don't want to encourage cervical spine injury. So we'll leave those out. So this person's on the ground and not really getting up. Functional status: patient may or may not display radicular signs and symptoms. Muscle weakness or inability to function is demonstrated. Cardiovascular and respiratory symptoms may be compromised depending upon the level of the fracture. So if you start talking C3, C2 for sure, we have some very significant risks of having cardiac involvement and respiratory involvement. And do not do range of motion if you suspect C-spine. So C-spine pain at level of the injury, typically bilateral weakness and loss of motor function below injury site. usually bilateral deficit, loss of sensation, blow injury, severe spasm in neck, pain, and then priapism in males. Do you know what priapism in males means?